Picture this. You're reviewing a 68-year-old man in your GP clinic. He's had a stent, his kidney function is drifting south, eGFR around 35, and his CRP is elevated. You've got him on a statin, an antiplatelet, maybe an SGLT2 inhibitor. He asked you if there's anything else to protect his heart and kidneys. For years, the answer has been, we're doing everything we can. This week, a major trial tried to add one more weapon to that arsenal, and the result changes how we think about inflammation in cardiovascular disease.
Good morning. It's Monday, the 4th of August, 2026. 4 stories today, plus quick hits. The theme running through this episode is negative trials and what we learn when a promising hypothesis fails. Let's get into it.
Story 1. Ziltivekimab, a monoclonal antibody targeting interleukin-6, tested in the ZEUS trial. This was Novo Nordisk's first cardiovascular outcomes readout for IL-6 inhibition. Over 6,300 patients with established atherosclerotic cardiovascular disease, chronic kidney disease, and elevated hsCRP above 2 mg per liter. Randomized to monthly subcutaneous Ziltivekimab 15 mg or placebo. Primary endpoint was 3-point MACE, cardiovascular death, non-fatal MI, or non-fatal stroke.
And the result was a clean miss. Hazard ratio, 0.99, confidence interval, 0.88 to 1.11, essentially no difference. This is despite the drug doing exactly what it was supposed to do at the biomarker level. Free IL-6 dropped, hsCRP dropped, the pathway was engaged, the clinical endpoint didn't move.
This matters for a specific reason. The inflammation hypothesis in cardiovascular disease has been building for a decade. We've had CANTOS with canakinumab showing a modest MACE reduction. We've had colchicine, the LODOCO-2 trial, showing benefit in chronic coronary disease. IL-6 sits downstream of IL-1 beta in the same cascade. It was a logical target. Ridker designed ZEUS to test whether blocking IL-6 directly would translate into fewer heart attacks and strokes.
Let me push back. These patients already had ASCVD, CKD, and systemic inflammation. Could the problem be that they were too sick for an anti-inflammatory to make a difference?
Fair critique. But the biomarker response was robust. IL-6 and hsCRP dropped substantially. If inflammation were the dominant driver of events, you'd expect at least a directional signal. The point estimate sitting exactly at 1 is a fairly convincing null result.
So what's the bottom line for the GP listening to this?
Don't wait for an IL-6 inhibitor to arrive in clinical practice. This was the first of 3 Novo Nordisk trials. The Hermes heart failure trial and the Artemis post-heart attack trial are still ongoing, with results expected early 2027. But for now, the message is that suppressing inflammation biomarkers alone is not enough. What actually works remains what we already have: optimal lipid control, blood pressure control, SGLT2 inhibitors, and lifestyle. The biomarker is not the disease.
That's the key insight. A normalized CRP does not equal a protected coronary artery. It's easy to fall into the trap of treating the lab value rather than the patient. Let's move to story 2, which has particular relevance for our anesthesia listeners.
Story 2. The GA-CARAS trial, published in Anesthesiology in January 2026. This is the General Anesthetics in Cancer Resection Surgery trial. 1,766 patients across 5 U.S. centers undergoing surgical resection of high mortality cancers: pancreas, esophagus, lung, stomach, bile duct, liver, bladder, peritoneal surface. Randomized to exclusive propofol-based total intravenous anesthesia versus volatile agent, sevoflurane, isoflurane, or desflurane for maintenance of general anesthesia. Primary endpoint was all-cause mortality at minimum 2-year follow-up.
This trial addresses a question that has been debated in anesthesia circles for over a decade. Does the choice of anesthetic agent influence cancer recurrence and survival? The biological hypothesis was that propofol preserves cell-mediated immune function better than volatile agents. Volatiles have been shown in preclinical models to suppress natural killer cell activity, which is critical for clearing circulating tumor cells released during surgery. Propofol, the theory went, would protect that immune surveillance and reduce recurrence.
The result was the opposite of what the investigators hypothesized. In the intention-to-treat population, propofol was not superior to volatile anesthesia. 26% mortality with propofol versus 23% with volatile. Hazard ratio 1.16, not statistically significant but numerically favoring volatile.
And in the per-protocol analysis, it was worse for propofol, wasn't it?
Correct. In the per-protocol population, those who actually received their assigned agent exclusively, propofol patients had significantly higher mortality, 25.5% versus 20%. Hazard ratio 1.31, confidence interval 1.05 to 1.64, p equals 0.017. Disease-free survival was also no better with propofol.
Let me be devil's advocate. This was a superiority trial designed to show propofol was better. When a superiority trial fails, you can't conclude the opposite. The per-protocol finding could be confounded.
Important methodological point. The per-protocol population is subject to post-randomization exclusions, but even in intention to treat, there's no hint of benefit for propofol. The direction consistently favors volatile. Protocol adherence was 96%. This was a large, well-conducted, pragmatic trial.
So what does this mean for the anaesthetist listening? For years, there's been pressure, sometimes from surgeons, sometimes from patients who've read about this online, to use TIVA-for-cancer surgery. This trial effectively closes that conversation.
It does. The practical takeaway is clear. Choose your anesthetic technique based on what's best for the patient hemodynamically, for recovery, for postoperative nausea and vomiting, for the specific surgical context, not because you think you're protecting them from cancer recurrence. The cancer outcome hypothesis for anesthetic choice is not supported by the best available randomized evidence. This connects back to ZES in an interesting way. In both cases, a biologically plausible mechanism failed to translate into clinical benefit. Biology is necessary but not sufficient. You need the RCT.
Well said. Let's move to story 3, which is a PBS change relevant to every GP managing osteoporosis.
Story 3. Abaloparatide, brand name Eladynos, is now listed on the PBS as of the 1st of August. This is a subcutaneous anabolic agent, a PTH-related peptide analog that stimulates new bone formation. 80 micrograms daily via a pre-filled pen, for up to 18 months. Recommended by the PBAC at the July 2025 meeting for patients with severe established osteoporosis and very high fracture risk.
What makes this significant is the positioning. We already have teriparatide and romosozumab on the PBS as anabolic agents. Why does abaloparatide matter?
3 reasons. First, it gives us an alternative for patients who can't tolerate teriparatide. Second, and this is the key point the PBAC highlighted, romosozumab carries a cardiovascular contraindication. It can cause myocardial infarction, stroke, and cardiovascular death. For the osteoporotic patient who also has cardiovascular disease, which is a very common combination in older women, romosozumab may be off the table. Abaloparatide does not carry that cardiovascular risk. The PBAC specifically noted it's not likely to cause the severe cardiovascular events associated with romosozumab.
And the efficacy?
The PBAC accepted that the evidence shows abaloparatide is as effective as romosozumab and teriparatide at preventing fractures. The original phase 3 trial, the active trial, showed about an 86% reduction in vertebral fractures compared to placebo over 18 months. That's consistent with the anabolic class. The PBAC recommended it for use in either first-line or second-line settings, matching the romosozumab listing.
So for a GP, the practical scenario is this. You've got a 75-year-old woman. She's had a vertebral fracture. Her T-score is -3. She's also had a stent last year, so romosozumab is contraindicated. Previously, you'd be stuck between teriparatide, which is daily subcutaneous and expensive, even on PBS, or just escalating her bisphosphonate. Now you have abaloparatide as another anabolic option that builds bone rather than just slowing loss.
Exactly. And the evidence increasingly supports using anabolic agents first line to build bone, then transitioning to an anti-resorptive. Having 3 anabolic options on the PBA strengthens that ability. The cost drops from roughly $600 per month private to $25 on general script, $770 on concession.
That's a practice-changing listing for sure. Let's move to our final story, which is about deprescribing, something every GP struggles with.
Story 4. A multi-level antithrombotic stewardship intervention published in JAMA Internal Medicine in June. The setting was the U.S. Veterans Health Administration. 7 intervention sites versus 128 control sites. The problem they were addressing is one you'll recognize instantly. Patients on a DOAC for atrial fibrillation or VTE who are also prescribed an antiplatelet, usually aspirin or clopidogrel, without a clear ongoing indication.
And this combination substantially increases bleeding risk. The literature consistently shows that adding an antiplatelet to a DOAC roughly doubles major bleeding risk, without a corresponding reduction in thrombotic events in most patients.
Correct. The intervention had 2 stages. Stage 1 was educational outreach to clinicians and patients, plus changes to the electronic health record. Stage 2 added a clinical pharmacist-facing electronic flag that identified patients on combination therapy. The primary outcome was the monthly percentage of DOAC patients also prescribed antiplatelets.
What did they find?
At baseline, 26% of DOAC patients were also on an antiplatelet. The combined intervention reduced this by an additional 0.6 percentage points per 6 months compared to control. The biggest effect was in stable coronary artery disease, where antiplatelet deimplementation is most appropriate. There, the reduction was 2.1 percentage points per 6 months.
Modest absolute numbers. Is this clinically meaningful?
In a quality improvement framework, yes. The intervention sites had nearly 28,000 patients on DOACs. A sustained reduction translates to hundreds of patients deprescribed. The stable coronary disease subgroup showed a 5.5% relative change. Both educational outreach and the electronic flag contributed equally.
The Australian context here is important. We don't have the VHA system, but the principle translates directly. How many of your patients with atrial fibrillation on apixaban or rivaroxaban are still taking aspirin that was started years ago after a stent and never reviewed? The ESE and Australian guidelines say that in stable coronary disease, meaning more than 12 months post-ACS or post-PCI, patients with atrial fibrillation should be on anticoagulation alone. Adding an antiplatelet is not indicated unless there's a specific active coronary indication.
The practical action for GPs listening. Run a report in your practice software. Search for patients co-prescribed a DOAC and an antiplatelet. Review each one. For most stable patients, the aspirin or clopidogrel can be stopped. This is one of the highest yield safety interventions you can do in a medication review.
Excellent point. And it connects back to our ZEUS story. Both are about avoiding therapeutic excess. In ZEUS, adding an anti-inflammatory to an already optimized regimen provided no benefit. In antithrombotic stewardship, adding an antiplatelet to an anticoagulated patient provides harm, not benefit. More is not always more.
Let's wrap up with quick hits.
Quick hit 1. The TGA has issued a safety alert about tranexamic acid, not about efficacy, but about medication errors. Cases have been identified internationally where TXA injection was inadvertently administered into the spinal cord instead of the intended intrathecal chemotherapy or anesthetic. The consequences are catastrophic: severe pain, seizures, cardiac arrhythmias, and deaths. The lesson for anyone working in procedural areas is simple but critical. Never store TXA alongside intrathecal medications. Use physically separate storage, ideally with warning labels.
Quick hit 2. Also from the TGA, reports of FluMist, the intranasal flu vaccine being administered in error to children under 2 years of age. FluMist is contraindicated in this age group due to increased risk of wheezing and hospitalization. If you're administering the nasal vaccine, confirm the child is at least 2 years old.
Quick hit 3. Ziltivekimab, brand name Eladynos, is now PBS-listed for severe chronic plaque psoriasis. This is an IL-23 inhibitor, subcutaneous injection. It joins the existing biologic options for psoriasis. trials, giving dermatologists and GPs another tool for patients who haven't responded to conventional systemic therapy. The PBS listing includes both whole body and face, hand, foot treatment phases.
Let's do the recap. 4 stories today. 1. ZEUS trial. Ziltivekimab, an IL-6 inhibitor, hit its biomarker targets but missed its clinical endpoint. No reduction in MACE in patients with cardiovascular disease and CKD. Don't treat the CRP, treat the patient with what worked.
2. GA-CARES trial. Propofol-based anesthesia does not improve cancer survival after cancer surgery. In fact, the per-protocol analysis suggested possible harm. Choose your anesthetic based on patient factors, not cancer biology.
3. Abaloparatide, Eladynos, now on PBS for severe osteoporosis, an anabolic option without the cardiovascular contraindication of romosozumab, a new tool for building bone in your highest-risk patients.
4. Antithrombotic stewardship. 1 in 4 DOAC patients are also on an unnecessary antiplatelet. Audit your practice. Stop the aspirin in stable patients. It's one of the highest-value safety moves you can make.
Quick hits. TXA must never be stored near intrathecal drugs. Check the age before giving Flumist, and Ziltivekimab is now available on PBS for severe psoriasis.
That's the episode. The theme today was that biology is not destiny. A plausible mechanism, whether it's IL-6 suppression, Propofol's immune effects, or an extra antiplatelet, means nothing without clinical evidence to back it up. The RCT is the arbiter. Stay sharp.
See you tomorrow.